course. Hello. So, okay, in today's webinar, we will be covering the basic course. We invite physicians around the world to join us and share their experiences with us. And thank you for joining us today. I'm Sevil Abdulmohammedian, third-year pediatrics resident here in Children's Medical Center, Pediatric Center of Excellence, Tehran University of Medical Sciences, Iran. And we are greatly honored to have with us today Professor David Gozal, Chairman Department of Child Health, Pediatrician in Chief, MU Women's and Children's Hospital, University of Missouri, USA, and an international expert in the field of sleep medicine. He is known as a pioneer in the study of childhood sleep problems and the relationships between sleep disorders and neurobehavioral, cardiovascular, and metabolic disease. We also have with us Professor Leila Khairandish Gozal. She's a tenured professor of pediatrics and director of the Child Health Research Institute at the University of Missouri, USA. She's one of the most celebrated pediatric sleep medicine experts in the world, ranking number 4 among the specialists in 2018. And we have Professor Athenius Kadatis, pediatric pulmonologist from University of Athens School of Health Sciences, Department of Pediatrics. Next, we have with us Professor Mohammad Reza Modarresi, Associate Professor of Pediatric Pulmonology, pioneer of pediatric pulmonology and sleep medicine in Iran, President and Chief Executive Officer of the Iran Cystic Fibrosis Foundation, Children's Medical Center, Pediatric Center of Excellence, Tehran University of Medical Sciences, Iran. So, Professor Modarresi, could you please have your greetings with us, please?
Hello and welcome to the first international virtual course on pediatric sleep medicine. We are so proud to be holding this conference for the first time. And we have the honor to have with us today distinguished lecturers from University of Missouri, USA, Professor Gozal, Professor Khairandish, Professor Medial, and Professor Kaditz. Okay. Thanks for joining to us today. The goals of this course are to provide the participants with the knowledge and skills needed to perform clinical care to children and adolescents with sleep disorders. This short course provides an overview of this topic and challenge involved for this population. The course is divided into 2 components. The first part, common topics, and the second part, advanced topics. The first part will provide basic and common topics in pediatric sleep medicine and key area of the management of sleep in children with disability. The second part of the course will cover the advanced topics such as interpretation of polysomnography, a specific consideration when undertaking non-invasive ventilation in children with disability, movement disorders during sleep, case presentation, particular aspects of ventilation strategies, of initiation and titrating therapy in the group of children and adolescents. A joining sign certificates would be issued upon completion of this course. Thanks everyone for joining us today. Thank you.
I'd like to take a moment to thank our dearest panelists for joining us today. I would also like to take this opportunity to thank Vice Chancellor for Global Strategies and International Affairs, Directorate of International Relations of Tehran University of Medical Sciences for giving me the privilege to patron this important event. I also would like to thank our dearest audience for joining us today. A few reminders before we get started. This webinar is streaming live on Facebook. Information about our social media is provided on the chat section. Please enter your full name, and there is no need to write your full name in the chat section. Just rename yourself so your name will change to the full name, and there will be no problem in your certificate. Due to the number of participants, make sure to mute your microphone during the lectures. If you have questions, we encourage you to ask them via chat section, and there's a webinar tool called Raise Hand, so we will be able to hear from you live after each lecture. We will reserve time at the end of each presentation to answer questions. We would do our best to answer as many questions as possible throughout today's event. And with that, we will open today's webinar. We are very lucky to have with us today Professor Athanasios Kadatis. Professor Kadatis, we are all ears.
Good afternoon. The aim of this presentation is to summarize the pathophysiology and diagnosis of obstructive sleep disorder breathing in children. So let's first discuss a few introductory concepts. So when we use the term obstructive sleep disorder breathing, we refer to a spectrum of abnormal respiratory patterns during sleep, which are characterized by snoring and increased respiratory effort. The main abnormality in obstructive sleep disorder breathing is intermittent upper airway obstruction. Thus, depending on the severity of the obstruction, sleep disorder breathing may vary from primary snoring, where we have only snoring without interruption in breathing, up to obstructive sleep apnea syndrome, which is the most severe form, and it is characterized by apneas, hypopneas, gas exchange abnormalities, and arousals from sleep. The main symptoms of obstructive sleep disorder breathing, which are directly associated with upper airway obstruction, are snoring, mouth breathing, reported apneas during sleep by parents, difficulty breathing during sleep, frequent arousals, and restless sleep. But of course, there are also daytime symptoms which are related to the intermittent hypoxia and sleep fragmentation, and they actually represent morbidity associated to sleep disorder breathing. And these symptoms are daytime sleepiness, hyperactivity and inattention, impaired cognitive functioning, and difficulties at school. To give you an idea about the magnitude of the problem, I will talk briefly about a study which was done several years ago in a large population of Greek children and adolescents.
I don't see your slides. I'm sorry, are you sharing the screen?
Yeah, yes.
Is everybody seeing the slides?
No, actually, I can't see the slides either.
Carlos, can you share slides, please? Sorry, everyone, there is a little technical problem. 1 second.
Yes, I can see the slides right now.
Okay. So
Maybe you just, I'm so sorry, Professor Karitis. Can you just quickly go back? Apologize for that. Because you're the first speaker, there's always the glitch for the first speaker. We apologize for that.
okay. So
is everybody okay now? Everybody sees the slides?
Yes, yes.
And
okay. So obstructive sleep disorder breathing refers to a spectrum of abnormal respiratory patterns during sleep, which are characterized by snoring and increased respiratory effort. Depending on the severity of upper airway obstruction during sleep, sleep disorder breathing may vary from primary snoring, which is not accompanied by interruptions in breathing, up to obstructive sleep apnea syndrome, which is characterized by apneas, hypopneas, gas exchange abnormalities, and arousals from sleep. Symptoms which are directly related to the upper airway obstruction are snoring, mouth breathing, reported apneas during sleep, difficulty breathing during sleep, frequent arousals, and restless sleep. There are also daytime symptoms which are related to sleep fragmentation and intermittent hypoxemia induced by obstructive sleep apnea. And these symptoms are daytime sleepiness, hyperactivity, inattention, impaired cognitive functioning, and learning problems. So in order to have an idea about the extent of the problem, in an older study on a large number of Greek children and adolescents, it was found that at least 10% of them were snoring more than one night per week. So this is a widespread problem. The main abnormality or the main abnormalities which are characterizing obstructive sleep disorder breathing is increased upper airway resistance and increased pharyngeal collapsibility. So children with sleep disorder breathing have higher upper airway resistance, and as a result, the diaphragm is required to create more negative than usual intra-airway pressure in order to overcome this resistance. During wakefulness, this is not a problem because the pharyngeal dilator muscles can stent the pharyngeal walls and can overcome the negative intrapharyngeal pressure. However, during sleep, when the tone of the pharyngeal dilator muscles decreases, the pharyngeal walls, under the influence of the negative intrapharyngeal pressure, either come close to each other, decreasing the cross-sectional area of the pharyngeal airway, or they collapse completely. So in this case, we have a complete airway obstruction and an episode of apnea. This is a good example from a study based on magnetic resonance imaging. And on the left, we can see the pharyngeal airway of a healthy child on inspiration and on expiration. So we can see that the airway is wide open and that there is little variation between inspiration and expiration. However, on a child with obstructive sleep apnea syndrome, we can see that even during expiration, the airway is somewhat more narrow compared to the airway of a healthy child. And surprisingly, during inspiration, the airway, the pharyngeal airway, becomes slit-like. So let's clarify a few terms. When we say apnea, we mean complete cessation of airflow through the upper airway, whereas when we say hypopnea, we refer to decreased airflow through the upper airway. When in addition to the cessation or decreased airflow, there is presence of thoracic and abdominal wall movements, we characterize these events as obstructive apnea and obstructive hypopnea. That means that although the respiratory center is functioning and stimulates the respiratory muscles to create respiratory movements, the airway is obstructed, and therefore there is either cessation of airflow or decreased airflow. And this is an example. This is like a small piece, a small part of a sleep study. So like on this tracing, we can see the thoracic movements. On this trace, we can see the abdominal movements, which reflect the movements of the diaphragm. And on the upper panel or the upper tracing right here, we can see the airflow. So here the airflow is normal. So during this part, there is complete cessation of airflow. There are still thoracic and abdominal wall movements. Therefore, we have an episode of obstructive apnea. And right here, we can see the concomitant reduction in the oxygen saturation of hemoglobin. And following this episode, we can see a second event, which is characterized by decreased airflow compared to the baseline. There are still air movements, there are still respiratory muscle movements like chest wall and abdominal wall. So this is an episode of obstructive hypopnea, which is accompanied also by desaturation. So now let's discuss in a little bit more detail the pathophysiology of obstructive sleep disorder breathing in children. The main conditions which predispose a child to obstructive sleep disorder breathing, or in other words, to upper airway resistance, increased upper airway resistance and pharyngeal collapsibility, are mostly the presence of adenoidal hypertrophy and the presence of obesity. Other causes include allergic rhinitis, nasal septum deviation, nasal polyps. These are abnormalities that decrease the cross-sectional area of the upper airway lumen and lead to upper airway resistance. And less common causes include craniofacial abnormalities and neuromuscular disorders. This is an older study from the US, which indicates the important role of obesity as a risk factor for obstructive sleep disorder breathing. So children who are obese have about 5 times higher likelihood compared to children who are not obese to be diagnosed with severe obstructive sleep apnea syndrome. So on this slide, we can have a better idea on the way that adenotonsillar hypertrophy restricts the airway lumen. So this is a view from the nasal choane by an endoscope, by a flexible, thin endoscope. So we can see that the pharyngeal tonsil is hypertrophied. So this is what we call adenoidal hypertrophy. And we can see how small is the cross-sectional area of the nasal choane. And on this view, which is like a view from inspection of the oropharynx of a child, we can see that tonsillar hypertrophy, of the pillar tonsils, leads to restriction of the oropharyngeal airway. One important thing is that in children without obstructive sleep disorder breathing, the adenoidal tissue increases rapidly in size from early age till the age of 8 years, and then slowly starts becoming atrophied or becomes smaller. And at the same time, the nasopharyngeal airway, the nasopharyngeal airway, as the adenoidal tissue becomes smaller, the nasopharyngeal airway becomes larger. However, in children with snoring, in children with obstructive sleep disorder breathing, the adenoidal pharyngeal tissue becomes enlarged very, very early in life and remains enlarged till adolescence. And on the other hand, the nasopharyngeal airway lumen remains restricted. And the same pattern is followed by the tonsils in normal children and in children with obstructive sleep disorder breathing. So these 2 figures remind to us that the view that the old view that a child who is snoring and has big adenoids and tonsils, we can leave him or her alone and the tonsils and the adenoids will become smaller. This is not true. This will happen in children who do not snore, but not in children who snore. Children who snore, unfortunately, most of the times will need adenotonsillectomy. Of interest, children with recurrent wheezing have an increased risk for tonsillar hypertrophy. So this association reminds us the fact that viral-induced wheezing has an important factor the overproduction of cysteamyl leukotrienes. So this association, this statistical association between history of wheezing, recurrent history of wheezing and tonsillar hypertrophy and snoring poses the question whether cysteamyl leukotrienes play an important role not only in the pathogenesis of asthma, but also in the pathogenesis of adenotonsillar hypertrophy. So in an older study from Dr. Gozal's group, when cysteamyl leukotrienes, and more specifically leukotriene D4, was added to a culture of tonsillar cells, the proliferation rate of the tonsillar cells in the culture increased in parallel with the increasing concentration of the cysteamyl leukotrienes. So this is like an indication from basic science that cysteamyl leukotrienes play an important role in the pathogenesis of adenotonsillar hypertrophy. Furthermore, the concentration of cysteamyl leukotrienes in adenotonsillar tissue of children with obstructive sleep apnea syndrome is much higher compared to the concentration of leukotrienes in tonsillar tissue excised from children with recurrent tonsillitis. So now let's move to the diagnosis of obstructive sleep disorder breathing. We do know for years now, the gold standard method for diagnosing the severity of obstructive sleep disorder breathing and making the diagnosis of obstructive sleep apnea syndrome is polysomnography. An important part of polysomnography is sleep staging and identifications of arousals. In order to be able to do that, as part of the study, EEG is included along with electrocardiogram and electromyogram of muscles movement, of muscle activation, and especially the submental muscles activation. So this is like an example of how the different derivations of EEG are placed. We do not need the many derivations that we need when we use an EEG in order to diagnose a seizure disorder. We are using a more limited montage, and this is like an example of how the leads for electroculography are placed. Finally, on this picture, we can see briefly how the leads or the sensors are placed in order to obtain the submental EMG. So the result of all these recordings is to get pictures like that, which allow us to characterize the different sleep stages and to recognize arousals from sleep. Furthermore, polysomnography is intended to identify respiratory events. So a series of additional sensors are included, such as a nasal pressure cannula and a thermistor, in order to be able to detect airflow through the nose and through the mouth, abdominal and thoracic belts, so that we can recognize the activation of the intercostal muscles and of the diaphragm, oximetry, pulse oximetry, in order to be able to identify intermittent hypoxemia, either end-tidal or transcutaneous capnography, which allows us to recognize the hypoventilation, a snoring sensor, a body position sensor, because the position of the body is important for upper airway obstruction. Upper airway obstruction is worst during the supine position, and especially during REM sleep. And also we are including an EKG in order to be able to recognize changes in heart rate, especially during episodes of upper airway obstruction. The most frequently parameter used in polysomnography in order to express the severity of upper airway obstruction is the apnea-hypopnea index. How do we calculate the apnea-hypopnea index? We add together the episodes of central apnea, and when we say central apnea, we mean interruption in the flow, but without chest wall and abdominal movements, because probably the respiratory center did not give the appropriate, let's say, stimulation to the muscles, to the respiratory muscles, plus the obstructive apneas, plus the mixed apneas, or in other words, apneas in which part of the cessation of the airflow is accompanied by movements of the chest wall and the abdominal wall, and part of the apnea is not accompanied by any movements, and the hypopneas, or the reductions in the airflow, as we discussed before. So when we add all these events and divide them by the total sleep time, the number that we get is the apnea-hypopnea index. So there is like a general agreement that children who have less than one episode per hour as apnea-hypopnea index, and they snore, they are characterized as having primary snoring, or in other words, they have a very mild degree of intermittent upper airway obstruction, so mild that they do produce the noise of snoring, but fortunately they do not have clear apneas and hypopneas. When the apnea-hypopnea index is between 1 and 5 episodes per hour, we talk about mild obstructive sleep apnea. And when the apnea-hypopnea index exceeds the 5 episodes per hour, then we can diagnose moderate to severe obstructive sleep apnea. A few years ago, a task force from the European Respiratory Society attempted to put together evidence which has been published over the previous years in order to propose an algorithm for the diagnosis and treatment of obstructive sleep disorder breathing in children. So the first 4 steps of the algorithm refer to diagnosis, so I'm going briefly to discuss them. So as a first step, even when we have a child in our general pediatric practice, we should try to decide whether the child is at risk for sleep disorder breathing. And the child is at risk for sleep disorder breathing if there are symptoms indicating upper airway obstruction, such as snoring or reported apneas during sleep. If on our physical examination, we can recognize abnormalities which predispose the child to upper airway obstruction due to increased upper airway resistance and increased pharyngeal collapsibility. And such examples are tonsillar hypertrophy, obesity, or the presence of complex disorders such as Down syndrome or Prader-Willi syndrome. If findings from objective examinations indicate upper airway obstruction, such as a lateral neck X-ray, which indicates narrowing of the nasopharyngeal airway, or the use of flexible nasopharyngoscopy by an ENT specialist in order to recognize adenoidal hypertrophy. And finally, the presence of past medical history, which we do know from the literature that is associated with increased risk for sleep disorder breathing. And such history includes premature birth and family history of sleep disorder breathing. So an example of an important condition which is associated with increased risk of sleep disorder breathing is the Prader-Willi syndrome. So in a meta-analysis of pediatric studies, including 224 children, it was shown that the overall prevalence of obstructive sleep apnea syndrome was approximately 80%. And of interest, most of these patients did not have symptoms that could be recognized by the parents. And in 50% of the cases, the OSAS was mild, whereas in the remaining cases, the OSAS was either of moderate or severe degree. As a second step, we do need to recognize the presence of morbidity associated with obstructive sleep apnea, or recognize conditions which coexist with sleep disorder breathing. You are going to hear about morbidity in subsequent lectures, but very briefly, I will refer to conditions from the cardiovascular system, such as elevated blood pressure, or from the central nervous system, such as excessive daytime sleepiness, or academic difficulties, or enuresis. And I will also refer to examples of conditions which coexist with sleep disorder breathing because they seem to share the same pathogenetic mechanisms. And such examples are recurrent otitis media, recurrent wheezing or asthma, as we mentioned before, the presence of metabolic syndrome, including obesity, and the presence of oral motor dysfunction. As a third step, we do need to recognize factors which predict persistence of sleep disorder breathing if it remains untreated. So such factors are obesity and increasing body mass index percentile, persistent tonsillar hypertrophy, and male gender. And this is important because in a few cases, snoring may be present for a few months, and then for a long time, snoring not to be there. So if a child is obese or if a child has persistent ocular hypertrophy, there is much higher possibility that if this child is left untreated, the OSAS is not going to resolve. And a good example of this concept is an older study from Tucson, Arizona, where they have followed children for a period of 5 years. So those children who either did not have sleep disorder breathing at baseline or over the 5 years of observation, sleep disorder breathing result, they had stable body mass index percentile. That means they were not becoming more obese as they were growing. On the other hand, children who had already obstructive sleep disorder breathing at baseline or developed sleep disorder breathing on the way were children who had an increasing body mass index percentile, children who were gaining more weight compared to the increase in their height over the 5-year period. The final diagnostic step is to objectively evaluate the severity of obstructive sleep disorder breathing and decide whether the child has the most severe form of sleep disorder breathing, which is obstructive sleep apnea syndrome. And this severity evaluation is necessary, especially when we are thinking about doing adenotonsillectomy in a child, when a child undergoes adenotonsillectomy but continues to have persistent symptoms despite surgery, and before and after certain interventions which are used to correct craniofacial abnormalities such as rapid maxillary expansion, orthodontic appliances, or the use of non-invasive positive airway pressure in children with neuromuscular disorders or craniofacial syndromes. Polysomnography, as we discussed before, is the gold standard method to decide or to evaluate the severity of sleep disorder breathing and to diagnose OSAS. However, as we all know, the sleep laboratory is a facility which requires complex and expensive equipment and a lot of effort and expertise from the side of doctors and of the people who work in the sleep lab. And as we saw in the slide with snoring in the Greek children, this is a very frequent problem. About 10% of the pediatric population snores more than one night per week. So fortunately, there are some alternative methods which are not as good as polysomnography. However, they do give us the opportunity to recognize the most severe children with OSA, and such examples are equipment used at home to perform polysomnography, or simpler equipment which is called equipment for polygraphy that does not involve the use of EEG, several questionnaires, and nocturnal oximetry. I'm going to very briefly refer to nocturnal oximetry because it's a simple method to diagnose moderate to severe OSA if there is no possibility that the child is going to have a full polysomnography study. So this is a tracing, an overnight tracing from a simple pulse oximetry study. And we can see that in a healthy child without upper airway obstruction and without lung disease, the tracing is almost straight. There are very few drops in saturation, and regularly, if there are no artifacts, there is no more than one drop in saturation below 90% over a full 6 to 8 hour oximetry study. However, in children who have intermittent upper airway obstruction and especially during REM sleep, what happens is obstructive events are accompanied by deep desaturations. So on the tracing, on the oximetry tracing of a child with moderate to severe OSAS, we can notice what we call clusters of desaturations, or at least 5 drops of 4% or more over a cluster period, over a period of 10 to 30 minutes. And there may be several clusters of desaturation over the period of a whole night in a child with moderate to severe OSA. So investigators from McGill University many years ago have developed a simple score to evaluate hypoxemia, intermittent hypoxemia in children with OSA who undergo nocturnal oximetry. So as they initially reported, and this was confirmed by subsequent studies, an abnormal study or a McGill oximetry score over 1 is characterized by at least 3 clusters of desaturation events and at least 3 drops in saturation to less than 90%. On the other hand, a child who has a normal oximetry or a McGill oximetry score of 1 has no clusters of desaturation events and no more than 1 drop of saturation below 90% for the whole oximetry tracing. Of course, and this is the weakness of the study, there will be a number of children who will have some clusters of desaturation events, but they will not fulfill the 3 drops to less than 90% over the period of 1 night. So they will be intermediate between a clearly abnormal oximetry and a normal oximetry. And these are like the inconclusive studies which correspond to children who may or may have not have OSAS. So in a subsequent study, it was shown that if the child has an abnormal McGill oximetry score, a score of 2 or more, we are over 90% sure that the apnea-hypopnea index is more than 5 episodes per hour. And this may be very helpful in making clinical decisions. So in summary, the pathophysiology of obstructive sleep disorder breathing involves increased upper airway resistance and increased collapsibility of the pharyngeal airway, resulting in collapse of the pharyngeal airway in the middle of the night, leading to apneas, hypopneas, and gas exchange abnormalities and arousals from sleep. Adenoidal hypertrophy and obesity are the most common predisposing factors, and obstructive sleep apnea syndrome is the most severe form of obstructive sleep disorder breathing. Regarding diagnosis of obstructive sleep disorder breathing, just the presence of snoring is enough to say that the child does have obstructive sleep disorder breathing. However, in order to decide whether sleep disorder breathing is enough to give the diagnosis of obstructive sleep apnea syndrome, we need to use polysomnography because it's the gold standard method. However, recognizing reality, other alternative tools like sleep questionnaires and nocturnal oximetry can be used in order to place the diagnosis of obstructive sleep apnea syndrome, at least in children with the most severe degree of upper airway obstruction. Thank you very much for your attention.
Thank you so much. I believe we have some questions. If you are ready, we have time to answer the questions, Professor.
Okay, thank you.
One question is, how do you compare diagnostic criteria for obstructive sleep apnea syndrome in pediatric population vs adult population?
In the adult population, this is a very good question. In the adult population, we accept more events per hour as normal. So whereas in children, a normal child with a normal upper airway does not have more than 1 episode of apnea or hypopnea per hour, in adults, you accept up to 5 episodes per hour. So this is a big difference.
Thank you. There's another question. Is there any link between SDB and epilepsy or AED effect on the pattern of breathing during sleep?
STB?
I do not
Sleep
know.
disorder breathing, okay.
Maybe. Yeah.
Okay, sleep disorder breathing and?
And epilepsy or AED?
There are a few studies showing an association between sleep disorder breathing and epilepsy. And the reason behind that is that when we refer to epilepsy, we refer to a very heterogeneous group of children. Some of these children may have just idiopathic epilepsy, but many others have neuromuscular disorders, craniofacial abnormalities, other genetic syndromes. So a collapsible upper airway is just part of the whole picture. So there is like association between the two entities. And on the other hand, many of the anticonvulsants, unfortunately, affect the tone of the upper airway muscles, leading to intermittent upper airway obstruction during sleep. So my answer would be yes, that if we have, although there isn't much published evidence, if I have in my practice a child with a seizure disorder, I would like in detail ask the parents about symptoms, the presence of symptoms of sleep disorder breathing during the night, and I would consider doing a sleep study or nocturnal oximetry.
Thank you. And we have another question. What is your idea about home sleep studies for diagnosis of obstructive sleep apnea in children?
Well, there isn't much evidence. It's not like the equipment for using, for doing a sleep study at home is like an established method of diagnosis OSA. I would say that there is much more evidence of using such equipment in adults. But on the other hand, we should admit that there are nice published studies like the one that I showed you from Tucson, where the researchers successfully have used exclusively equipment for polysomnography at home. So I would say that if there is no way that the child can have a sleep study in the lab, in the hospital, that it would be an excellent idea if somebody is familiar with equipment which can be used at home, to use this equipment and try to help himself and the family regarding the diagnosis of OSA.
Thank you. And another question is, what is the fate of childhood, OSA? In fact, will it proceed to the adulthood obstructive sleep apnea or not?
Could you repeat the question, because it
What
was...
was the question?
It was, they mean that if whether the childhood sleep apnea will turn to become an adulthood issue or will it resolve spontaneously?
This is an excellent question, which has been tried to be answered from many researchers now. I would say that we do have a lot of data that the disorder runs in families. There are also some genetic data, not a lot, but some. So I would say from clinical experience that unfortunately, the way that our airway is constructed, the way our muscles of the upper airway are controlled, is most likely genetically controlled, and unfortunately OSA runs in families. Therefore, if a child has OSA in young age and he gets adenotonsillectomy and he or she gets better, unfortunately many years later, if no efforts is made for the child not to become obese, for example, the child is very likely that will develop OSA as an adult. So the answer to this question is, although there aren't tons of evidence, the answer is yes. Unfortunately, yes.
Thank you. Thank you so much for answering the questions. And if there are any questions, I will be informed in the chat section. So I would like to ask Professor Leyla Khairandish, would you please have your speech, Professor?
Sure. Could you tell me, do I share screen right now?
I need Professor Kat. Okay. So he has stopped sharing. Yes, it's okay. Have you opened your slides?
this slide, and then I put it on a speaker.
Okay, if your slides are open, you just click on the share screen option. And
Do you see my slides?
no. After clicking the share screen, you need to choose your PowerPoint slides in the opening screen.
One second. I'm going to. Do you see something? Do you see something?
No.
How about now? See anything?
Nothing. And I believe your voice is muted.
How about now?
Yes, yes. We have your voice, but no slides.
Now? Anything?
No, we do not have your slides. What's the problem? Just tell me where's the problem, and maybe I can help you.
I have two screens. That's the problem. No?
No. If you can send the files for me, I can share it from here.
Okay. How do I send it to?
Yes, you have my email.
A second. Just a second.
Okay.
Restart again. Share screen.
Yes, yes, yes. Something is happening here.
What
And we have your screen, and I believe we have your sons here.
Oh, okay. You see?
Okay, we have your slides full screen.
Sorry, I'm aged. Oh, so you see the full slides, right?
Yes, yes.
Right. Thank you. And you hear me?
You're welcome. Yes, yes, your voice is loud and clear, and we're all yours.
Yeah. When you're ready, I will start.
We're ready?
I am. Thank you. All right. Well, thank you everybody for bearing with me. I apologize for my lack of technical ability. As you can imagine, I'm a little bit older than many of you. And I'm very honored and very, very pleased to be invited and participate in this unique and very first of the kind a joint lectureship with University of Tehran, which is extremely near and dear to my heart, my homeland, where my father actually was graduate, and for many years it's been very good collaborative efforts between me and Dr. Modarresi and many other colleagues that I see their names participating today in that course. So big hello and salam to everyone that I know, and they are all there. So good to see you, although it's virtually, and I wish I could be there. So my task today is to talk about the morbidity associated with obstructive sleep apnea. And as you can imagine, when you have such a disorder that is not just stopping at the upper airway, it's something that goes on and on every night, stopping you from every few minutes, giving you upper airway constriction, upper airway obstruction, giving you few seconds of lack of oxygen and increase in your carbon dioxide. With that, you get increase in your thoracic pressure. The negative pressure causes the multiple things that your body has to deal with, changing your metabolism, changing your vascular dysfunction, increase your hypertension, changing your insulin process, causing insulin resistance, changing how your body hormones has to process, gives you excessive daytime sleepiness, which is another lecture you will hear later on, increases systemic inflammation in your body, causes later on atherogenesis, and meanwhile, not only physiologically changes a lot of things that in this simplistic slide, I'm just showing a few of those just to have in mnemonics, but socially, you also have a lot of other things that you can see. Most children, especially in children, you see manifestations of attention deficit, concentration difficulties. You see children that have memory problems. They have school behavioral problems. They have social isolation. I don't know where that line comes from. Somebody just made a line on my slide.
Yes, dear participants, please control your screen.
Hyperactivity, inattention, and lack of adaptive skills. Now, to add that, obesity, tango with obstructive sleep apneas, knowing that these days, most of the children that walk into your sleep clinic, unfortunately, because of the change of lifestyle, most children are inactive. They are sitting in front of TV. They're, unfortunately now because of Corona, it's very, very clear that most children actually are not going to school, or they're not as we used to be as children, play outside, go run in the park, etc., etc. So children are less active. The lifestyle is changed. Everything is in the car, everything is drive-through, everything is less active and more sedentary life. And therefore, obesity has become a real phenomenon and a real pandemic by itself. Add that to obstructive sleep apnea, you add that to asthma, you add that to many other things, and together, obstructive sleep apnea has become a real true monster. Now, to speak about multiple comorbidities that can come together for obstructive sleep apnea, I decided to start. Can we get rid of that line, however it came through? I don't know where these coming from.
I do not know either, but that's a thing that we cannot control. I would ask the dear participants to just control their screens.
Sorry, Professor, may I ask you what is the problem?
Somebody's drawing some lines on the slides.
Draw the lines. Okay, I will remove the lines.
Thank you so much.
Thank you. Yeah, please don't line up. Thank you. So let's talk about the one of the manifestations, that is the neurocognitive consequences. I started to talk about neurocognitive consequences because I think this is very, very common and quite interesting to me, as it is to many of you colleagues. It's an interesting topic. It has been going on for the last probably 20 years, but it started as a very, very interesting topic when the very first study was shown. I like to show this study because this was a very first study that was almost considered as a hallmark, a setting a stone that started the whole attention that was brought to the topic. Until back in almost 200 years ago, when the very first observation happened, the very first professor that said children that have Pickwick-like behavior and disease, they have stubborn, they look stupid. We specifically use word stupid, which is completely inappropriate. But the physician noticed in that very old publication that children actually, when they are not breathing well, they actually look like they are less intelligent. Years and years later, they keep noticing something about these children is different. Not all of them, but severe cases. Later on, somewhere in 1998, Professor Guzal did a very simplistic study, which was one of a kind at the time. And this was the very first time that somebody actually came and put the impossible in a very simplistic way to show that upper airway resistance and upper airway obstruction is actually associated with changes that happens in a school performance. Until then, most of the people thought upper airway changes is just something that is related to oxygen level, it is related to your breathing, and it has nothing else to do with your brain activity, it has nothing else to do with anything that you can actually measure. They thought it was just a matter of respiratory problem, ENT problem, and that's about it. In this study that I would explain it, he went to a school, a bunch of schools. He asked for the first graders, teachers, to, in each class, to give him 2 students that were worst in the class. As you can see in this very simplistic graph, he went to the first graders of each school, asked the teachers to give the worst students grades, and also show him the worst students, 2 students from each first grade. And then he went to the parents of those students and asked if he could have a sleep study, home sleep study on those kids. Now you may say, why home sleep study? Why not a pediatric sleep center study? Because he had no budget. So he had to go home and do that on his own. He was a fellow at that time. When he did the sleep study for these kids, results was many of these kids actually had obstructive sleep apnea. Then he told the parents of those children that had obstructive sleep apnea, as you can see, a large number of these children had a sleep apnea and they needed treatment. And he told the parents they need to be treated with adenotonsillectomy. Some parents said we would like to, and some parents said we don't care. He then, after a year, when they went to second grade, went back and repeated again the free, no-cost home testing for the children that had the sleep treatment, which was basically done at surgery. And he got the grades collected again from the same kids. And also collected the grades from the kids that their parents said, we don't care, we don't want to treat anything, and who cares? As you can see, there was a tremendous improvement in the kids that their adenotonsillectomy was happened, and children that parents said we don't care stayed the same or they got worse. This was a phenomenon because nobody until then thought that academic performance, grades getting better, could have been helped by treating a disorder, a disease that was just at that time stopping at the level of the head and neck. This actually opened the door for our colleagues in neurosurgery, in neurology, in behavioral science and psychology to enter the field of sleep. As you can imagine, this was huge. This became the very first time that actually the behavioral sciences entered the sleep medicine. Since then, it had been hundreds and hundreds and hundreds of studies, including our group, that had been working on the effect of obstructive sleep apnea on neurocognitive and behavioral issues. This is one of the morbidities that I'm going to talk about. Now, today, it's completely known that, as you can see, with children with obstructive sleep apnea or snoring compared to many other children that are their age, their gender, and their size, they have problems with processing. They have longer processing thoughts. They have, visual and auditory attention problems, social problems, thought problems. They have aggressive behavior. It is completely known that children that have obstructive sleep apnea, they more likely to bully children at school. or being actually bullied. They have externalizing problems. These are concepts that are in the psychology, and they have verbal comprehension ability problems. Attention deficit-like behavior is part of their issues. So many of these children are unfortunately labeled as if they have attention deficit, but they don't have it. They're not ADHD, but if they have a sleep fragmentation and they are sleep fragmented or sleep deprived, or they don't get a good night of sleep, they actually act such that they are considered hyperactive. And many of them by mistake are given stimulants when they are actually, in fact, they are not ADHD. This is a video of a child in Tibet, as you can tell. He's a sleep-deprived, miserable child that has been forced to study. As you can see, this child is resisting to sleep. He doesn't want to, he is sleepy, and look how he's trying not to fall asleep. And look how his body is resisting, but he really is sleepy. And you probably have seen this in school. So you can see that a child that is falling asleep can't really remember much from what he's learning. And I'm sure that that child didn't grow up to be Dalai Lama or something. But meanwhile, another option is that what happens when a child is not getting enough sleep. Look at this little one who has planned his escape from his crib very, very cleverly. This is a child that is barely a year and a half old. This little one has planned and used something that is called executive functioning. This kid, as you can see, he has found, using his part of his intelligence that is called executive functioning, a way and a system to fold his mattress, put himself down, push his bed to the side of the other bed. And this is really a mastermind. This is Breaking Bad all the way. He's a prisoner, he's trying to plan his escape. And this is a very, very clever way for a child of his age to find his way getting out. You can tell this was not taught by somebody to him. So this child actually had found a way of doing that. Well, we look at it and we like it. We want every child to be smart like that. But if this child has obstructive sleep apnea, this behavior, this type of problem solving and being able to find solutions for things that they like to do is sort of defected. So that's called executive functioning, and there is a deficit in the children that are either snoring or have obstructive sleep apnea. Something else I wrote here that is super important, that 2 lines that I wrote there is probably a result of 15 years of investigation, only from our group at least. I wrote here that attention deficit is usually a result of a sleep fragmentation and increased arousal index. And trust me, this is a result of many multiple research and investigation that we have done specifically in rodent models. We know that when a sleep is fragmented, not necessarily when oxygen level is low, or not necessarily when you have a high severity of apnea-hypopnea index, that's when you get mostly the attention and memory problems. But when you have a behavioral issue, some kid that has attitude issue, behavioral, acting bad, moody, that's when you actually have somebody with a very, very lower oxygen. So if somebody says, how about the kid that has a very severe obstructive sleep apnea? I would say that's where I expect to see bad behavior. But if a child is not actually sleeping enough or has a lot of awakenings, that's where the kid actually is quiet. The kid is not giving you a hard time, but he cannot remember lessons that he has learned in school. Another problem, morbidity that is associated with obstructive sleep apnea and is known, and we've published on it in our group, is bedwetting. In neurosis, is now known that due to increased brain natriuretic peptide levels in the brain, actually is associated with obstructive sleep apnea. And when you treat, and when I say treat, I mean successful treatment of obstructive sleep apnea, you can actually completely eliminate, or you can actually improve the obstructive sleep apnea and reduce the neurosis. This, of course, considering that there are no other reasons, either primary or secondary reasons for a neurosis. There is no UTI, there is no other reasons for the neurosis. Another issue that I would like to show, I don't know if you can see the top part, is the effect of the obstructive sleep apnea on another type of our intelligence that is called declarative memory. How we use our memory for functioning. As you know, when we learn something, there are two ways of learning, and there are two types of memory for us. We have a short-term memory, something that right now I learned your name, you learn my name. And maybe in 5 minutes, I may remember or may not remember your name again, or you may not remember my name at all. And there are people that tomorrow or 5 months later, they still remember your name. So how it works is that some people have a very good retain and recall of something they have learned, and they can acquire that memory very well. And some people, they can't. So the long-term and short-term memory, the way it's collected in children with obstructive sleep apnea, apparently this is completely dysfunctional. Now, this was a hard thing to show because we knew that to show this in a normal setting of a sleep center, you had to be a real psychiatrist, you need to have a series of tests. And it was really difficult because many of us, we're just sleep doctors. Most of us, our training and background is either pediatric, neurology. It's not really psychiatry or psychology. And it's very cost associated and time consuming. Let's say a sleep center doesn't really have any of that, or for the purpose of research, we really needed a system that is much easier. So we came up with a very simplistic type of experiment. So we use a very simple book that I actually happen to have it here. I'll show you. A simplistic, let me just bring it. This is a good thing about being on Zoom. You can actually show up. So a simplistic book with animal pictures. As you can see, this is animal pictures in the book. And I show this book to the kids and I tell them, hey, let's look at this children's book. These are the children that came to the sleep center normally, and they were supposed to have a study. So I showed the book to say, hey, you want to play a game? Let's look at the kids, look at this animal book. This book was not something research-wise, it was just a simple book. And as you can see, it has animals' names, and they are familiar animals. They are not very exotic or difficult. So dog, butterfly, cow, you know, animals that at least I know, so it's not difficult for me. And then I closed the book and I said, okay, let's see if you remember which animals we saw. And usually the kids remember, you know, I just showed you what? Dog, cow, butterfly, something like that, right? So we remember 3 of maybe 5 I showed. Maybe one of you there remembers 4, another animal. So that's trial 1. Then I open the book again and say, let's look again. What do we see? Horse, parrot, I don't know, pig, chicken, expensive chicken, fox, owl, and then again, close the book all the way to the end. Of course, right now because of lecture, I'm not going all the way. And you guys are too intelligent for my test. It's not fair. So that's trial 2. And every time we recorded how many of these names the child is remembering, every time. So trial 1, trial 2, trial 3, trial 4. Every time between trials, there was a time. This is short recall. It's quick and it's short recall. And then I said, okay, thank you so much. Here's a sticker or whatever, bye-bye. And I didn't tell the kids that I'm gonna come back later. And I didn't tell the parents I'm coming back. And of course you can imagine why, because not everybody's, like us, but I'm pretty sure if parents knew that I would come back the next day to ask about those names again, they would, the whole night, they would repeat it with their kids to make sure that they remember it the next day. So in the morning, I showed up and I said, hey, remember last night we saw some animals? Do you remember which ones? And then the kid will repeat them for me and I will score and write down which ones they remember. Now look at this. The ones in the black versus the ones in the circles that are white. The ones in the circle that are white are children of the same age, same sex. Like if it's a boy, matched to a boy that is a 6-year-old, that is a 6-year-old. But the boy 6-year-old versus a boy 6-year-old, one has a sleep apnea, one doesn't have a sleep apnea. And how do I know? Because they had a sleep study. The 6-year-old boy took longer time to learn the number of children that the same age and sex child without a sleep apnea took. It took him longer to remember and learn. However, the next day, although both of them learned the same amount of children, the next day, the child with the sleep apnea couldn't remember the same amount. How does it translate? Very simple. You sit, you study with your child, you help your child to study for exam. They are, let's say, 2nd grade, 3rd grade. You study with them. They memorize capitals of the countries. You teach them, I don't know, something that they have tomorrow exam at school. You ask them questions, they answer you, you say bravo, you learned your thing, you're gonna go to the exam tomorrow. They come back, they didn't ace the game. They come back and they didn't get the perfect score. And you say, why? Didn't you know the answer yesterday? What is wrong with you? What is wrong with you that you didn't get the perfect score? And the kid says, Mom, Dad, I couldn't remember. They are not lying. They couldn't remember. Because their longer memory, their long-term memory is actually affected because they have something in their brain not functioning the way it should. Now, another concept. Again, another effect of sleep apnea when it's not treated is on actually how kids feel empathy towards another. What is empathy? Empathy is how you sense somebody else's pain. Now, we know that children that are having obstructive sleep apnea, it's been many studies that shown that children that are having a sleep apnea or a snore, they're actually 3 times more likely to have been either bullied or being themselves the kids that pick up fights and bully other kids at school. They grab the kid that is younger, smaller, weaker, and they beat up or they pick up fights. Unfortunately, there is an area, the functional MRI has shown that there is an area in their brain that is affected. This is not something simple. This is very serious problem because there is an actual physiological thing behind it. It's not just the kid is tired, the kid is moody. No, there is something actually malfunctioning in their brain. And you want to see how serious it is? I will show you. Now look at the left side. In the middle, you see an image. If you are a normal person, you see somebody's hand is stuck and you close the car's door. If you're a normal person, which I hope you are because you're physicians, and I really, true to God, I really hope you are, your reaction should be like this gentleman on the right, like, ow. That's a reaction of a normal human being. Your area of the brain that I'm showing, I hope you see that arrow that I'm showing. It should be a reaction in your part of the brain that is called amygdala. Your amygdala should react in response to the perception of intentional harm to another person. And that is the meaning of empathy. That's the area of empathy in your brain. That's also the same area that you have the self-image. Self-image empathy is where amygdala activates. Now, if you're a serial killer or cannibal, like Dr. Lecter, which is an imaginary fictional character on the left, you see, oh, nice, his finger got cut, awesome. That's the reaction of serial killers. That's why serial killers or criminals like that, they can actually kill people, cook them, eat them. It's as if they have no feeling. It's like they see people as a chicken, as a meat. They don't see them as a human. They can do whatever they want to a person as a doll. They don't have a sense towards the pain of others. Imagine a child that has severe obstructive sleep apnea or has obstructive sleep apnea and is untreated, has a problem in that specific area of their brain. And this is not something I'm just saying. This is based on many, many studies we have done. And the publications are available. Worse than that, this is based on almost 10 years of my life in the past many years, and publications are up here. Mona Philby was a very bright fellow that she came from Saudi Arabia and worked with me. You can see this publication that really made a lot of noise. Not only you have changes in behavior, your function, etc., etc. Look at the areas that you see on the left. Everything yellow is the actual erosion that happens to the surface of the brain, the cortical areas of the brain that was eroded. We showed with the functional MRI that not only your brain is affected, not only the function of your brain is abnormal when you have obstructive sleep apnea, the actual layers of your brain, your cortical gray matter, actually is eroded. That's why there is a reason that you lose about 10 to 12 points of IQ when you have untreated obstructive sleep apnea for a long time. Now, if you are a father, if you are a mother, you have a young child that snores, has obstructive sleep apnea, you better run to Dr. Mudarisi. And I'm serious about that. If I know that my child, which I am sure every one of your children are bright, is having such a problem, wouldn't you want to stop that problem? Wouldn't you want to take care of it? Now, you may say, well, 10 to 12 points, my child is super, super intelligent. His IQ is above Einstein. IQ of 130, 140. Who cares? He's still going to be #1 in concours. Who cares? Right, you're right. You're right. But think about a relative, a second-degree cousin, or I don't know, somebody else, a patient that comes in and his IQ is average. IQ is average. And then they lose 10 to 12 points. This person that is already started with a lower hand definitely will not make it to university, college. He may not even get a diploma. He may not even graduate. That's a person that would never get a job. That's a person that would become a burden in the family, a burden on the society, a burden for himself. He would not be able to function the way he should, when in fact, he could have been fixed really quick, really simple. If it was something that didn't have a solution, I would say, well, sorry, that's life. But truthfully, there is a solution, and we know what is the solution. We know the disease, we know what it does, and we know the solution. Why not to take care of it? Now, based on all the things I said, just look at it. This is another simplistic figure. I like figures because it makes things easier for me to explain. If this is your quality of life, it's just downward when you have such problem. It's one disease. I'm just talking about one disease. Look what it does to you. You're socially isolated because you're in a bad mood. Imagine you're a doctor You are every night, every few minutes, getting a little ring from your phone or little buzz, and that nobody is there, and you fall asleep again. And a few minutes later, another buzz, and then you fall asleep again. Do you have really a good mood in the next morning? I don't think so. And imagine that happens every night. That's called a sleep fragmentation. That's called a snoring. You're depressed. You're unhappy because you don't remember your lessons. You keep studying, you don't remember, you don't get good grades. You're a little bit hyperactive. Your parents don't know what's wrong with you. You're not paying attention to teacher because all you want is sleep. Nobody understands what's wrong with you. You're really, really during the day sleepy. You sleep, they keep saying, why? You are sleeping 7, 8, 9 hours a night. What is wrong with you? It's not like you're not sleeping. Yes, you are sleeping, but you're not getting quality sleep. And overall, you're miserable. So do you think you have a good quality of life? No. Another problem, just sending children, pay attention to this one, just sending children to surgery doesn't mean that you're actually treating them. You may say, well, let's just treat everybody. Let's send everybody to surgery. Sure, let's do that. But remember, only 30% get 100% cure. Cure being apnea, hypopnea come to less than 1. Our colleagues and friends, ENTs, don't like this part of the lecture ever. But truth has to be told. Like everything else, research is right here. Evidence is here. Majority of children, they get better. 30%, you can see, 30%, this is our own publications, and many other groups have confirmed it for many, many years. This is a publication from 2006. 14 years now, everybody knows this. So about 30% of children still have residual obstructive sleep apnea. You say, why? That's another lecture. I will give it to you when the next courses happen. This is a basic course. Now, you know, this is the tip of the iceberg. We're going to have many, many other levels of course. This is a very basic and the beginning. You would like to hear about it, you come for the next courses. However, this is 30%. They don't even get better. Why? Because they have obesity, because they have obstructive sleep apnea that is associated with systemic inflammation, because they have asthma, because they have other comorbidities, and I will explain that to you later. Now, funnier than that is what you heard from Dr. Pediatric, genetic. There are some lucky people, man, I hate those. They are obese. They are severe obstructive sleep apnea, and there is absolutely nothing wrong about their vasculature. There is nothing wrong. They never get a heart attack. Have you ever had one of those uncles that they smoke until the last day of their life? They ate whatever they want and they lived like 100 years. And you tell them, why is this never dying? And they say, well, good genes. There is something also here. Similar to that, there is almost a small number, about 37%, that actually have severe obstructive sleep apnea and obesity. And they're, for example, their blood vessels are absolutely not affected. And this was a puzzle for years and years and years. And now we know why. Because they don't get a vascular dysfunction. And these lucky people, these fat, choking, lucky people, they have genes that protects them. That's another whole version by itself. And that's about the genetics that protects you. What genes actually are involved, that you can have it or not have it. And that's about the genetic that is actually involved with obstructive sleep apnea. Now, based on what I said, which my purpose was to confuse you, is obstructive sleep apnea, if you have it, is bad. It has negative consequences. If you treat everybody, well, it's not a good thing because not everybody needs a treatment. And if you don't treat everybody, then it's bad. So who should we treat? Well, if medicine was supposed to be easy, everybody would be a doctor, right? I just talked about the inflammation. There is a genes involvement. There is a genetic. There is multiple years. and studies by our group and many others about pathways that are involved and activated based on what pathways are actually activated and the inflammation response that is going on. Obstructive sleep apnea is just one word, but there is a whole world and career behind it that is full of science, and you need to go deeper to figure out what's going on. There are many, many, many new perspectives into the obstructive sleep apnea science that you have to know. We are now using proteomics, genomics, epigenetics to figure out what is behind this disease. And we are finding many new ways of measuring it rather than just going to a sleep study, a sleep study, a sleep study. Very quickly, in the near future, you may be able to even have just a blood test to say obstructive sleep apnea, yes or no. You may have even a pill that you can take or something to drink or eat that may reverse your obstructive sleep apnea. Wait for that. Overall, obstructive sleep apnea is a balance. From one hand, you have good things. You have the tolerance that a human has, such as healthy diet, using your brain, physical activity, intellectual activity. And from another hand, all the bad things you can do. You can have the inflammatory response in your body. You can have how bad the disease is. You can have the heterogenetic diet. You can have the genes that are not good that you already inherited. You also have external things that is out of your hand. For example, obesity, environmental modifications that is not in your hand. You may be in a very polluted air. You may be a premature baby. You can have asthma. Things that is not something that you wanted, but is forced from the environment to you. All of these changes how your response and how your OSA is changed. So this is probably one of the funniest slides I have, but overall, you have to consider environment, obstructive sleep severity, and individual susceptibility. They are all meshed together. You can't say OSA is just one thing. OSA has multiple things involved with it, and I just talked about it. At the end, as physicians, we have to know which one to treat. They're identical, triplets. Do you treat a child that snores but has no comorbidity or symptom? Do you treat a child that snores and has symptoms and comorbidities? Or do you get a child that sometimes snores, wet the bed, and has behavioral issues? You as a physician have to decide, and that's the most important thing. I will leave you with a bunch of names of our group, people that are involved in many research, and this is just a few names, and the two clowns that are dancing in the middle are actually my own kids. Thank you for listening.
Thank you, Professor Khairandish. It was a great presentation. Actually, I believe I share the same problem with the poor kid in Tibet, being a pediatric resident as it all. And I believe we have a question. If you're ready, I will ask it.
I'm sorry, how do I stop sharing?
What?
How do I stop sharing this?
There's a option in bottom of your screen called stop sharing. Yes, it's we do not have your screen anymore. It's all okay. So I want to ask you, is there any relation between speech delay or problems and obstructive sleep apnea?
Yes, there are, and I'm not specifically versed in that topic, but yes, there are publications about that. Yes.
Thank you. And there's another question. Do all patients with ADH, I believe they mean ADHD, need to screen for obstructive sleep apnea?
If they snore, yes. And if do every patient with ADHD needs to?
Needs to screen for obstructive sleep apnea?
Yes, absolutely. It doesn't mean that everybody needs a sleep study, but yes. if they have at least a snoring or something related to their sleep, yes, absolutely, I recommend that.
Thank you. Thank you so much. Let me check.
Are you reading the questions from the chat?
Yes, of course. If you want, you can read and answer them directly.
Oh, let me see what.
Dr. Behdad Qarib has asked the question, are relations between nutrition and feeding behavior or specific foods and sleep disorders? If you can see his question in the chat section.
No, I haven't seen it yet. I'm sorry, can you repeat that?
Are there relations between nutrition and feeding behavior or specific foods and sleep disorders?
I don't know in specific, but if you have a colicky baby, that might be. But to say that obstructive sleep apnea specifically is related to a certain type of food, no. But GERD by itself and colicky babies, if you have a baby that has a digestion problem, yes, but not specifically directionally.
Thank you. And there's another question. Memory consolidation occurs during the sleep. Does it happen during daytime nap too?
Daytime nap?
Yes, daytime nap.
Yes, there are two times that there are twice in the sleep. You have the slow wave sleep and you have the REM sleep. That where the memory actually is consolidated. So depends on your nap, what kind of nap you have. If it's a deep nap or you have a very shallow nap, based on the quality of your nap.
Thank you. Another question is there any possibility that some children may be asymptomatic for obstructive sleep apnea?
Yes, definitely.
Okay.
You may have an upper airway resistance syndrome. You may have a very mild OSA. You may have a child that actually doesn't manifest any kind of typical symptoms, but actually has OSA, and it's possible. Like I said, there actually have quite a bit of OSA, but they actually are fine. They don't show any problems. It's unbelievable. Sometimes they are very interesting, and you would expect their OSA to be unbelievable, and it's not. And sometimes it's opposite. You see a skinny kid that is just quietly sitting there, and their OSA is up the roof.
Okay, thank you.
I said about the genes. Some people, I have seen one that I remember we called him Fat Billy. And as he walked, he was a 12-year-old. I said, we were fellows, we were just guessing. And I said, I was 30, and somebody else said 25. We were just guessing what is the AHI for that kid. He had no obstructive sleep apnea. He had no cholesterol. We thought the lab made a mistake. We actually, the three fellows, we went and reread the study. There was nothing wrong with Fat Billy.
So good for him.
He wanted McDonald's when he was there for his study. There was nothing wrong with him. And we were like, oh my, this stayed with me for years because I couldn't believe somebody was that lucky.
Yes, I cannot tell anything.
We were like, unbelievable.
Yes, unbelievable. So there's another question. What is the indication for I just lose the screen. What was the question? What is the indication of polysomnography for adenoid hypertrophy?
What is the indication for PSG, for adenoid hypertrophy?
Yeah.
What do you mean by that? I'm sorry.
I believe Professor Modarisi can.
Dr. Modarisi, I didn't understand the question. I'm sorry, sir.
Hello, Professor.
جانم بفرمایید.
Okay. What is the indication for PSG? Because sometimes we do polysomnography before adenoid tonsillectomy. What is the indication? Yeah, for polysomnography before the adenoid tonsillectomy.
Well, if the tonsils are obvious, if you really have resources that are not as much, if The sleep study is expensive. Patient doesn't have it. The timeline is very, very long. Money is a problem. Waiting long is a problem. And you want to save, or really it's an issue. I would suggest that don't do the before one, at least do the after one. Rather not to do the before one, before the surgery. Go ahead, take those big balls out, but make sure after you have done the treatment, you take to make sure there is no residual afterwards. The most important one.
Yeah.
Because if you look at somebody's mouth and you see these huge tonsils, I think that's not a hard decision to make. Airway is obstructed. Do I need a sleep center to tell me it's obstructed? I see it. Do you need a sleep study to tell you it's obstructed? No, an X-ray of a head and neck, lateral X-ray of head and neck, you can see that obstruction. You don't even need a sleep study for that. You can see it and take it out. That is easy. That's my thing. Would you agree?
فارسی فرمودید. من جا داره تشکر ویژه کنم چون اکثر حضارم ایران هستن. از حضور
خیلی ممنونم از دعوت شما آقای دکتر.
لطف فرمودید.
کوچیک شما.
Thank you so much. There's another question. Any correlation between microbiome and obstructive sleep apnea?
بله 100%. Definitely. This is an absolutely new avenue. We are actually heavily working on it. Our group has multiple projects on it. Microbiome is a very new thing. As we speak, we're working on it. We're collecting the fecal samples. Actually, recently, I'm joking. If you look at the board behind me, not this one, but there's another one. It's like fecal sample. So I call myself poop doctor now because every project I have has a little fecal sample collection in it. And with Dr. Kalitis, we were just talking that our life is now collection of poop. So as funny as it is, we are actually, it's a new avenue that we believe that certain food can actually change how your systematic body reaction is changing. And it is very possible that by changing your microbiome, we may be able to change the severity of your disease. Now, very, very recent publication, which I can share here, if you like, as a PDF. And I think everybody can download the PDF from the chat.
Yes.
Once the speaker starts, I will share that PDF here so all the participants can actually download it while we're talking. It's a publication that just came out from our group about 3 weeks ago. It really made a very large noise, but very quickly, this is an experiment. We took animals that were models of animals of obstructive sleep apnea. We took their fecal sample, basically their poop, and we feed it to the animals that were identical, but they didn't have obstructive sleep apnea. And you won't believe it. The animals that were normal, after they received that fecal sample from animals that had obstructive sleep apnea, they started to have obstructive sleep apnea. Now, right? So by the same token, we are hoping that we can take the normal we're hoping that we can take the poop from normal animals, give it back to the ones that have obstructive sleep apnea, and make them not have
Okay, we'll try to do that.
But yeah.
Thank you. There's another question for you. Do you think treating children with neurocognitive consequences of obstructive sleep apnea only with medications may worsen the issue?
I mean, medication, it depends on what medication and what's neurocognitive consequences. I mean, are you talking about ADHD child? Are you talking about a child that has specific behavioral issues? Depends on the deficit that is there. If there is something that requires behavioral help, if there is a child that needs cognitive behavioral therapy, it is known in the field that usually medication in combination with cognitive behavioral therapy is the best way to treat. At least that's what I know. However, if a child is depressed, you need to have medication. If there are certain things that requires medication, and there are certain things that requires medication and family help and social help, and there are certain things that no matter what you do, an autistic child needs a medication and the family help and the schedule and the routine hygiene for the sleep, etc., etc.
Thank you.
Underlying a sleep problem, that a sleep issue has to be resolved.
Okay, thanks. And there's another question about the surgery. After surgery, if
mild OSA is seen. If
yes,
obstructive sleep apnea is below 5, use the anti-inflammatory. If the obstructive sleep apnea is 5 and above, definitely use CPAP.
oh, thank you.
Obstructive sleep apnea after surgery.
Okay.
Dr. Ademi, what about myofunctional exercise? The myofunctional therapy is an up and coming lecture by itself. Definitely we'll have it in the next round. And it's a new topic. It's very interesting. Also, you know, the expansion of the jaw in the use of orthodoncy and new techniques. I'm sure Dr. Ghazal would talk about that in the future lectures. Yes, these are definitely, the myofunctional therapy is a new thing. Unless there is a significant research that shows and proves that it's working. Right now, what we have is based on basically cases, very sporadic cases. However, there is no doubt that if there is a craniofacial abnormality that can be fixed, should be fixed. Then
Thank you.
from Dr. Khameneipour, what is the relationship between ODI and hyperactivity? What do you mean by ODI? Is that the apnea-hypopnea index and hyperactivity? Well, children manifest their sleepiness with hyperactive behavior. They are not hyperactive per se. When children are sleepy, instead of sitting down like us adults and just, you know, be a little bit quiet and doze off, they actually start bouncing off. They start to walk around and bounce off the wall and jump around and be agitated. That's how they show their sleepiness. What do you think about DICE in children? What is that? Vida Imani. Dr. Imani, what is the DISE in children?
So I believe we are a little short in time. Maybe she will type in the chat section. Oh, yes, drug-induced sleep endoscopy.
Drug-induced sleep endoscopy. What do you think? Not much. Has there been any study on the disorder, the adults who have suffered from OSA in their childhood? I am not aware of such longitudinal study. Might be, but I am not aware of that. And it might be just lack of my knowledge. I don't know. But we do know that there's a specific gene that is actually affected with intermittent hypoxia. Is that any idea to use physical, oral, or nasal devices to bypass transfer? Are we past the time?
Yes, I believe we can.
Okay. I would leave my email if you like, or during the next day or after the other, because I don't want to take away from my colleagues. So if you don't mind.
Thank you. Yes, of course.
Thank you all for listening. Thank you very, very much. I appreciate it.
It was a great lecture, and now I will share Professor Modarres's speech here. Let me just share it.
Hello everybody, I am Modarresi, pediatric pulmonologist, Pulmonology and the chairman of Department of Pediatric Pulmonary and Sleep Medicine in Children's Hospital of Tehran University of Medical Science. My lecture is about hypoventilation syndromes in children. Alveolar hypoventilation is defined as insufficient ventilation leading to hypercapnia, which is an increase in the partial pressure of carbon dioxide and measured by arterial blood gas analysis. Alveolar hypoventilation is caused by several disorders that are collectively referred to as hypoventilation syndromes. Hypoventilation syndromes may cause clinically significant hypoxemia and hypercarbia. What are the causes of hypoventilation syndrome in children? The specific hypoventilation syndrome, which will be discussed in this presentation, include the following causes. Obesity hypoventilation syndrome, OHS, in children, central hypoventilation in children, hypoventilation due to chest valve deformities in children, hypoventilation causes by neuromuscular disorders in children, and finally, chronic obstructive pulmonary disease in children and related hypoventilation. At first, I'm going to discuss obesity hypoventilation syndrome, OHS. OHS is a well-known cause of hypoventilation, and the definition of OHS in children is as the following criteria. The first criteria is obesity or BMI greater than 30 kg per m2, or body mass index greater than 95 percentiles for age and gender, or overweight greater than 95 percentile for age. The second criteria is daytime hypercapnia or PaCO2 greater than 45 mmHg. Absence, and the last criteria is we have to rule out other causes that produce hypoventilation or absence of unknown neurological, cardiac, or pulmonary causes of hypoventilation. Approximately 90% of patients with OHS also have obstructive sleep apnea. Hypoventilation is worse during rapid eye movement in a sleep stage, and during non-REM sleep. So we have hypoventilation. We have more hypoventilation in REM stage than in non-REM stage. Obesity hypoventilation syndrome, previously referred to as Pickwickian syndrome. What is the prevalence of OHS? The prevalence of OHS in the pediatric patients is not known, but in the adults, the prevalence of OHS in adults with obstructive sleep apnea is estimated to be about 10 to 20%. Yes, the pathogenesis of OHS is not fully understood in adult and children, but there are some possible mechanisms in adult for obesity that cause hypoventilation and hypocapnia. The first one alter, as you see here, as this slide shows us, alter upper airway mechanics such as upper airway resistance or impair respiratory mechanics, decrease FRC, and gas exchange deterioration respiratory muscle weakness, and neurohumoral influence. All of them cause increase in sleep PaCO2 or PaO2 or gas exchange, and increase workup breathing, blunted ventilatory drive, and finally chronic daytime hypercapnia. What is the clinical presentations of OHS or obstructive hypoventilation, obesity hypoventilation syndrome in children? In contrast to adults, the phenotype of OHS in children has not been well characterized, and the clinical presentation of OHS can range from children being asymptomatic to present with acute respiratory failure. There are some presentation in children with OHS, asymptomatic, as I told you, asymptomatic to acute expiratory failure, snoring, apneas, headache, daytime sleepiness, altered cognitive function, and the left or right heart failure. There is limited evidence for associated morbidity and of OHS in children. In adult, increased mortality, increased hospitalization, poorer quality of life, increased incidence of heart failure, angina, and pulmonary hypertension, and both in children, it is expected that the children will also experience increased morbidity and mortality with a shortened life expectancy, but there are no studies that have evaluated outcomes or prognosis in children. Quality of life has been reported as improved in obese children treated with positive airway pressure therapy. What are the treatment modalities of OHS in children? Evidence for treatment of OHS in children is limited, in contrast to adult literature. Treatment in adult consists of weight reduction strategy, exercise, dietary modification, pharmacological approach, and or bariatric surgery, and also positive airway pressure therapy, such as continuous positive airway pressure or non-invasive mechanical ventilation. In rare circumstances, a tracheostomy and invasive mechanical ventilation may be needed to fully correct the degree of hypoxemia and hypoventilation. There is overall insufficient evidence for NIV, including methods, outcomes, cost, and benefit, and for home mechanical ventilation in children with OHS or obesity hypoventilation syndrome. At best, any reference are drawn from adult data. In children, we need more research for these following questions. What is the optional treatment choice? Non-invasive modes, ventilator modes for children with OHS. This is the first question. Another question, is weight loss sufficient in children with OHS to fully correct their sleep gas exchange abnormalities? The third question, that we need more data. What are the morbidities associated with OHS in children? And another question, what are the outcomes associated with treatment of OHS in children? Change in quality of life, neurocognitive function, daytime sleepiness, and metabolic parameters. The second type of hypoventilation syndrome in children is hypoventilation due to chest valve deformities. The most common chest valve deformity, abnormalities or deformities to cause hypoventilation in children is kyphoscoliosis, leading to respiratory insufficiency and respiratory failure. What is the pathophysiology of alveoli hypoventilation in children with chest wall deformities? In pediatric patients with chest wall deformities, hypoventilation develops secondary to decreased chest wall compliance, with a resultant decreased tidal volume, decrease in vital capacity, and expiratory reserve volume. Alveolar dead space is unchanged, but the VD to VT ratio is increased due to the reduced tidal volume. These patients, children patients, usually are asymptomatic until the late stage of disease, when the most severe deformity of the spine has occurred. If the restrictive impairment progresses, the patient will eventually be unable to maintain adequate alveolar ventilation, first during sleep and then during wakefulness. Hypoventilation will be worse dramatically at REM sleep state due to relative atonia of accessory muscle of respiration. Non-invasive positive pressure has become the most common treatment modality. Non-invasive positive pressure ventilation in patients with kyphoscoliosis and ventilatory failure improves daytime and nighttime oxyhemoglobin saturation, respiratory muscle performance, symptom of hypoventilation, quality of life, and pulmonary hypertension. The combination of non-invasive positive pressure ventilation plus oxygen lead to greater improvement and survival than oxygen alone. Another type of hypoventilation syndrome is hypoventilation in neuromuscular diseases in children. Neuromuscular diseases in children that can cause alveolar hypoventilation include SMA, myasthenia gravis, Guillain-Barré syndrome, and muscular dystrophy. Patients with neuromuscular disorders have rapid, shallow breathing secondary to severe muscle weakness or abnormal motor neuron function. The central respiratory drive is maintained in patients with neuromuscular disorders. Thus, hypoventilation is secondary to respiratory muscle weakness. Patients with neuromuscular disorders have nocturnal desaturation that are most prevalent in the REM stage of sleep. The degree of nocturnal desaturation is correlated with the degree of diaphragmatic dysfunction. In the absence of acute illness, the first signs of respiratory insufficiency occur during sleep when skeletal muscle tone is generally decreased and episodic generalized atonia REM sleep occur. This leads to arousal, obstructive apnea, and hypopnea, sleep fragmentation, poor sleep quality, and eventually sleep hypoventilation. There are some recommendations for hypoventilation due to neuromuscular diseases in children. The experts strongly recommended assessment of gas exchange during sleep for any patient with signs or symptoms of hypoventilation. Assessment of gas exchange during sleep in any patients with baseline forced vital capacity less than 40% of predicted, and awake baseline end-tidal partial pressure or carbon dioxide greater than 45 mmHg, and or an awake baseline SpO2 less than 95% in teenager and older patients. What is the screening test for neuromuscular disease? Screening tests are required to detect sleep disorder breathing in children with neuromuscular weakness before the advanced finding of daytime hypercapnia develops. The polysomnography provides monitoring of cardiorespiratory function, including heart rate, breathing frequency, abdominal and chest wall movement, nasal airflow, oximetry, lip movement, sleep position, and video monitoring during sleep, as well as simultaneous monitoring of sleep with continuous electroencephalogram and electromyogram, and finally electrooculagram. For patients with neuromuscular weakness, it is also critical that exhale and or transcutaneous CO2 or carbon dioxide is monitored as part of the study to detect nocturnal hypoventilation. In general, the goals of chronic mechanical ventilation support in children are to prolong survival, relieve dyspnea, normalize gas exchange, correct sleep disorder breathing, and abnormal sleep architecture, prevent or reverse core pulmonary, improve daytime function, and promote and sustain growth and development. Non-invasive ventilation can also alter chest wall growth in children with SMA. The use of NIV with inspiratory pressure greater than 14 centimeters of water has been shown to prevent or reverse the development of pectus excavatum. The overall meaning of death of these subjects who did not receive mechanical ventilation support was 17.5 years, but it was significantly higher, about 27.9 years in those who use mechanical ventilation. As I mentioned before, the NIV can also alter the chest wall growth. As this slide shows us, there is the NIV reverse the development of pectus excavatum in the patients. When should NIV be started for children with neuromuscular disease, hypoventilation due to neuromuscular disease? There are no validated criteria to start long-term non-invasive ventilation in children with hypoventilation due to neuromuscular diseases. Cough assistance technique should be implemented at an early stage before the onset of nocturnal hypoventilation. Even at any early stage, acute respiratory failure can be precipitated by a respiratory infection or anesthetic procedure, underlying the importance of preventive measures. With the progression of respiratory muscle weakness, the patient will develop continuous nocturnal and daytime hypoventilation. Daytime hypoventilation might postpone the discussion of a tracheotomy, which will need to be discussed at the time of end-stage respiratory failure. When we initiate the long-term NIV in children with neuromuscular disease, in clinical practice, periods of reduced ventilation or paradoxical breathing associated with a pulse oximetry less than 90% and or a transcutaneous carbon dioxide greater than 50 mmHg, we can initiate the long-term NIV in children with neuromuscular disease. Another type of hypoventilation syndromes in children is central hypoventilation, or CHS. Central alveolar hypoventilation disorders denote condition resulting from underlying neurological disorder affecting the sensors, the central controller, or the integration of the signal. This disorder can lead to insufficient ventilation, an increase in PaCO2 or hypercarbia, as well as in a decrease in PaO2 or hypoxemia. Congenital hypoventilation syndrome can either be congenital or acquired. Central hypoventilation syndrome is exhibited typically as a congenital disorder, but in rare circumstances can also result from severe brain or spinal trauma or injury, such as ischemia, traumatic disorder, ischemia, inflammatory injuries in the brain stem, or brain stem injury in brain stem region due to surgery. As I mentioned before, central hypoventilation syndrome is exhibited typically as a congenital disorder. In congenital central hypoventilation syndrome, this type of hypoventilation usually presents during infancy with episode of cyanosis, apnea, or even cardiorespiratory arrest. Children with congenital central hypoventilation syndrome have been described as having a square face with a tall, flat forehead and deep fulcrum with downturned lips. Some children will present outside of infancy and even in adulthood, maybe with the sequela of long-standing hypoventilation and hypoxemia, including epilepsy or cognitive disabilities. In older individuals with hypoventilation associated with respiratory infection or anesthesia, congenital central hypoventilation syndrome diagnosed in children over 1 month of age is termed late onset congenital central hypoventilation syndrome. What is the treatment of CCHS? At present, no medications have been shown to increase ventilation sufficiently and with sustained action or to prevent patients with CCHS from assisted ventilation. During assisted ventilation, it is important to achieve normal oxygenation and normal range for PCO2, ideally between 35 to 45. As I mentioned before, the only treatment for CCHS is assisted ventilation. So it is the first line of treatment. There are 4 types of ventilatory support in CCHS or congenital central hypoventilation syndrome. The first one is positive pressure ventilation via tracheostomy. The second one, positive pressure ventilation via mask ventilation or non-invasive ventilation. The third one, pharynx nerve pacing, and the last one, negative pressure ventilation. Patients with congenital central hypoventilation syndrome have so many special needs. These needs include the close monitoring of growth and development, regular echocardiography or pulmonary artery pressure to gauge the pulmonary artery pressure, and electrocardiographic monitoring to assess for asystole, particularly with symptoms of dizziness and syncope, periodic ophthalmologic evaluation, management of respiratory infection, limitation of sporting activity to non-contact sports, and to moderate exercise which may rest periods. Swimming carries significant risk. Close attention and object monitoring after sedation and anesthesia. Needs genetic study for FOX2B. Infants with central hypoventilation at birth or in first month of life. Patient with unexplained central hypoventilation manifesting after the first month of life. Hypoventilation manifesting in the setting of general anesthesia or sedative use. Adult presenting with unexplained central sleep-related hypoventilation. Patient affected by Hirschsprung disease and hypoventilation. Patient presenting with neural crest tumors and hypoventilation. Patient presenting hyperinsulinism in association with hypoventilation. Any child born to a parent with known congenital central hypoventilation syndrome. Parents of children with CCHS. And finally, patients with hypoventilation associated with rapid onset obesity and abnormal disturbance. Here is another central hypoventilation, another type of central hypoventilation syndrome. Rapid onset obesity with hypothalamic dysfunction, hypoventilation, and autonomic dysregulation, ROHAD. ROHAD, also known as late onset central hypoventilation with hypothalamic dysfunction. The presentation of ROHAD are rapid weight gain, hypothalamic endocrine dysfunction, and severe hypoventilation. Children often present increases such as respiratory failure or pulmonary. This is a growth chart of a patient with ROHAD from the birth to 36 months, presented with light onset central hypoventilation with hypothalamic dysfunction and rapid weight gain. The last type of hypoventilation syndrome is hypoventilation due to chronic obstructive pulmonary disease in children. The classic type of chronic obstructive pulmonary disease is in adult. The chronic obstructive pulmonary disease is typically in adult smoker older than 40 years. But in children, the COPD occurs secondary to genetic or environmental changes. There are airway inflammation and infection, although the symptoms of COPD are very similar in children, in all types of COPD in children, but they have variable in etiology, morbidity, physiopathology, prevalence, prognosis, genotype, and phenotype. Here are some types of COPD in children: asthma, cystic fibrosis, bronchopulmonary dysplasia, primary ciliary dyskinesia, non-cystic fibrosis, bronchiectasis, plastic bronchitis, and bronchiolitis obliterans or BO. Hypoventilation in COPD is not uncommon in patients with severe COPD. Alveolar hypoventilation in COPD usually occurs when first expiratory volume in the first second is less than 30% of predicted value. However, many patients with severe airflow obstruction do not develop hypoventilation. Therefore, other factors such as abnormal control of ventilation, genetic predisposition, and respiratory muscle weakness are likely to contribute. Here is a sample or example of chronic obstructive pulmonary disease in children, I mean cystic fibrosis. Cystic fibrosis is the most common life-shortening genetic disorders in Caucasians. With the improved treatment that have become available, the median survival for patients with this disorder has increased to 37.5 years of age. Unfortunately, the overwhelming majority of patients still die from respiratory failure and hypoventilation. What is the treatment of hypoventilation in cystic fibrosis? Here are some suggestions. The first one, respiratory muscle training. The second one, oxygen therapy. And the last one, non-invasive ventilation. The non-invasive ventilation are used in the treatment of hypoventilation in cystic fibrosis. But we need more data for the best treatment for cystic fibrosis, hypoventilation in cystic fibrosis, and also other forms of hypoventilations due to chronic obstructive pulmonary disease in children. Thank you for your attention.
So thanks, Professor Modarresi. Thank you for joining us with your speech. Now, I believe we have Professor Gozal. So shall we proceed to the discussion with Professor Gozal? We are all ears. Professor Gozal, could you please unmute? Do you have my voice, Professor Gozal?
Yes, I can hear you. I'm trying to share the screen,
okay.
Which hopefully will work, in which case we will be in good shape.
Dear Professor, may I assist you?
I'm very familiar with the program. Here, I found it.
Yes,
setting.
we have your screen.
Yeah, good.
Sorry to interrupt. In order we do not have the drawing on your slides, please stop the participants' drawing. Only you can stop that.
So you want me to stop sharing? Is that what you want me?
No, not stop sharing.
Stop sharing. Just stop the participants' drawing. Yes,
The
we have now
lines.
drawing on the slides. On the bottom line, you can see the options, and in the options there is a stop drawing, stop participants annotation. Actually, it is annotating. They are annotating.
Well, I'm sharing the screen, but it doesn't allow me to do anything about it. So.
Okay, I will remove the annotations.
Disable and okay, I did it. Okay.
Thank you. Thank you so much.
Thank you. Well, good afternoon, everybody, and it is my pleasure to participate in this initial symposium that reunites two wonderful universities, the University of Tehran and the University of Missouri. I'm David Gozal. I'm a professor of pediatrics and chairman of the Department of Pediatrics and physician-in-chief for the Children's Hospital at the University of Missouri. My major specialties are neonatology, pulmonary, and sleep medicine. And today I will be telling you, beginning our conversation about the treatment of sleep apnea in children. I believe that this will be a long conversation that hopefully will take us to future meetings and symposia. So I'm planning to stimulate your curiosity a little bit today, and then go from there to tell you more about some details about some of the things that are the more common, and then leave the rest to the future, because obviously treating sleep apnea is something that requires quite a bit of attention to detail, and I don't want to overload today the presentation. Trying to see whether I can, okay, here we go. It's now responding, so great. As usual, everything can go wrong, will go when you don't want it to. Okay, here we go. So you have heard quite a bit already, I believe, and we'll hear certainly more about the pathophysiology. So, but sleep apnea is very frequent. It affects up to 4%. But if we really take, and you'll talk about diagnostics and so on tomorrow from Professor Kadidis, you know, it is a frequent disease, and so we need to be aware that we need to know, be able to diagnose it, and understand the pathophysiological risks, and then these will, of course, inform the treatment. And one of the important things is the fact that at least in the US and certainly across the world, we're seeing a major pandemic, not of COVID, but of obesity. The one with COVID, hopefully, will disappear very quickly, but the one for obesity will be a little bit more difficult to control and to reduce to what it used to be. And so it is important to understand what to expect from treatment on the basis of the patient that you are taking care of. And so I wanted to emphasize before I start on the treatment thing, that obesity may have a very important contribution as a risk factor. And so this study, which was done by Dr. Habdayat when he was with us as a fellow, we took 416 children with OSA, but divided them into two groups. One of obese children and one without obesity, on the basis of obviously BMI Z-scores and percentiles. And what we did was to match them for age. So for each case of sleep apnea, we identified the age, the gender, the ethnicity. As you know, there's risks, the different risks of ethnicity related, and the AHI. In other words, the sleep study needed to have the same AHI on both groups, so that all of them had sleep apnea, all of them were matched for all these four conditions. Now, why was that important? Because what we wanted was to be able to look at the size of the tonsils, and this is the standard way of categorizing tonsil size, and I would suggest and encourage you to use this in your clinical practice. This is available. We look at four categories, all the way from 1 to 4. 0, of course, is absence of tonsils, but tonsils that are +2, +3, and +4 were eligible in our group to be involved in the study. But we do this as a routine for every child in every clinic that we see our patients. The second technique that we use in order to quantify what we call the crowdiness of the airway is called the Mallampati. Now, the Mallampati was not developed for this. This was developed by an anesthesiologist really for the difficulty to intubate. But we have found that it is a very good technique to look on how crowded the airway is. In other words, all the airway structures can really affect the ability to look into the upper airway. And so this helps us look at the crowdiness, particularly in children. And so what were the findings? Well, what we found is that if we looked at the obstructive apnea hypopnea index, in other words, the index of severity of the sleep apnea, as a relative percent of the percentile of the BMI, there was absolutely no relationship. There was absolutely no correlation. There was some very weak correlation that, by the way, has been noted by other authors before this, so this was not new, it's just confirmatory, that the sleep apnea severity was on a R square of 0.2, 0.17 or so, relative to the adenoid size and tonsillar size using a standard score. So whichever way you quantify the adenotonsillar tissue size, you're going to get that there's some relation. The bigger the tonsils, the bigger the adenoids, the more likely that you will have more severe sleep apnea. But the relationship is not very strong. And you all know this from your clinical activities, where there will be a child with kissing tonsils so tight, and so big that there seems to be no space there, and yet they don't have sleep apnea. And there will be children with minimal adenotonsillar hypertrophy, and they will have significant or severe sleep apnea. So the relationship is, and you will talk much more about it from Dr. Kaditis. But the important part was that the Mallampati score was always much higher in children with obesity. In other words, if the Mallampati score was high, that whether they were less than 5 years or 7 years of age or more than 7 years of age, it didn't matter. All children, independent of their age, if they were obese, had a much higher Mallampati score, which then made that the size of tonsils and adenoids, in order to achieve the same degree of severity, you remember we matched for AHI at the beginning, you didn't need that much bigger size of tonsils or adenoids for children with obesity, which means that if you have a size 3 in 2 children, one is obese, the other one is not obese, the child who is obese will more likely to have a more severe sleep apnea. But this indicates that there are other factors that do not relate to the tonsils and adenoids that contribute to the severity of sleep apnea, and this is important for treatment, which is that why I am emphasizing this from the very beginning. So back in 2003, Andy Lipton, who was one of my fellows at the time, very bright young man, did a meta-analysis. And you know that published evidence, most of the publications, look at the positive side. We don't like to publish negative results. So we need always to take a look in a very critical perspective at anything that is published in the literature, because negative studies are unlikely, not as likely. In fact, they're only 20% as likely as positive studies to be published in the literature. So if you do a study and you publish and you get a good result, in other words, a positive result that proves the hypothesis, you have 5 times more chances of publishing it than if the same study done with the same quality, everything else, but that the results do not confirm your hypothesis. Then you will only have 20% probability of publishing. So with that in mind, what we found from a meta-analysis of published evidence, it's suggesting that adenotonsillectomy, or TNA, leads to significant improvements in the vast majority of cases. But really, looking at the data more closely, and this paper in 2003 was published in Sleep Medicine Reviews, we looked at and challenged the concept that maybe there was a little bit over-optimism about the efficacy of adenotonsillectomy. And now, as you remember, also in 2002, the first American guidelines from the American Academy of Pediatrics by Carol Marcus. Professor Marcus unfortunately passed away. She was a very dear friend of ours, and we are very sorry and feel very bad about her passing away, at such a young age. But she published the first guidelines of the American Academy of Pediatrics, which we repeated back 10 years later in 2012. And the impression was that adenotonsillectomy was it. We didn't need to do anything else. And yet 1 year later, we using this meta-analysis, we actually challenged that concept. And I will show you a little bit what that has resulted in. So a few years later, Dr. Riva Tauman, who was again one of our fellows, she did a very nice study looking consecutively at 110 children with sleep apnea who underwent adenotonsillectomy and systematically underwent a repeat sleep study after their adenotonsillectomy, usually between 10 to 12 weeks after the surgery. And what she found was that in 30 to 40% of these children, there was a mild residual sleep apnea, which will be defined with an AHI of more than 5. In other words, clearly an abnormal result, and yet The parents were totally unaware that these kids, these children, were actually had abnormal sleep studies. And so these are the results. You can see very interestingly that there were three groups. A group that was cured, but only 28%. Now, we defined cure, and this may not be wrong because cure means that the child will never have sleep apnea, but maybe at age 20 or 30 or 40, he will come again and have sleep apnea. And Professor Guilleminault, again, one of the giants of sleep medicine in pediatrics and adult medicine, really pointed out that there was a very high risk of recurrence for any child developing sleep apnea as a child to develop the same sleep apnea many, many decades later. But the important part is that only 28% of the children had normalized their sleep study. And you can see that there was a group of 45% with mild, between 1 and 5, and a group that had relatively quite substantial sleep apnea of 27%. This important observation led us to then do a much larger study. And Dr. Rakesh Bhattacharjee, who was again a fellow of ours, who is now the director of the Sleep Center at the University of California in San Diego, did a multi-center retrospective study in 578 children. We identified all the centers that did as a routine sleep studies post-adenotonsillectomy and defined three conditions, the same that Dr. Tauman did. We identified those that failed their adenotonsillectomy, in other words, their obstructive apnea-hypopnea index after their adenotonsillectomy was more than 5 per hour. Those that retained a mild sleep apnea or had upper airway resistance syndrome, defined as an apnea-hypopnea index of 1 to 5 per hour total sleep time, and those that in whom we defined as curative, their AHI was less than 1, in other words, fulfilled the criteria for being normal. And these are the criteria, these are the characteristics of the population, a very typical population in any of your clinics, mean age between 5 and 7, but of course across the whole range, a little bit of a dominance of boys. Please note that in the United States, we have about 51% obesity. These numbers actually increased a little bit since then. And then the usual story, a very frequent 30% or 40% with asthma, rhinitis, allergic rhinitis, prematurity, family history of sleep apnea. So clearly a very frequent and a very characteristic type of population. And this is just to show the age peak that you see between ages 2 and 7, which is really the typical distribution of most of the cases that we see in our clinics. And what was important is the following, and therefore I've highlighted it in color, that if you take the obstructive apnea-hypopnea before the TNA, the average was about, the mean was 18 events per hour. So clearly a severe sleep apnea that went for surgery, but you notice that it was not normal after. It was 4.1 with a high degree of variability, with a very large standard deviation, indicating that there were kids that were clearly not resolved and had significant disease, and those that actually were cured. And so what we found was exactly the same. 27% of the children had a normalization of the sleep study. About 40% remained between 1 and 5. And again, another 28% or 30% had residual sleep apnea. And when we looked using what we call composite statistic modeling and what is called the Wald statistic, to look at what the factor loading would explain the variance in the response to therapy, what we found was that there were 4 elements that were significant. One was the age. If the child was younger than the age of 7, the likelihood of resolution was much higher than if the child was older than 7. So that was point number 1. And this is important because this
Professor Gozal, I believe we do not have your voice. I think he's disconnected, so let's give him a minute to reconnect.
I believe that that somehow we lost connection, but
Yes.
are we good? Are we good again?
Yes, we're good.
Okay. Maybe I'll come back to this slide so that you don't lose the important information that is here. So what we found is using what we call a very significant composite modeling was that there were 4 major factors that contributed to the success or failure, whichever way you want to look at it, of the adenotonsillectomy.
I'm sorry we lost him again, but I'm sure he will come in a minute.
Obviously, we're having some technical difficulties. I don't think that Zoom likes my slide.
But we like it. We definitely like it.
Well, let's try it again. So
Okay.
in this study, there were 4 major factors that determined the success or failure that were significantly involved or contributing to the success or failure of the treatment of sleep apnea. Can you hear me again? Is that okay? Okay. So age 7, the cutoff being 7. If you were younger than 7, the likelihood of success was higher. If you were obese, obviously the likelihood of success was less. If you were more than 7, the likelihood of success was less. If you had asthma, there was also more likelihood of having residual sleep apnea. And if you had severe sleep apnea, then the likelihood of success was also not as high. But you can see that age and BMI are really the major loading factors. They are very, very large compared to asthma and sleep apnea. Sex, allergic rhinitis, ethnicity had no influence on this result. Trying to again, as I mentioned, in this study, there were, as we had found before, that only 27% of the children we had actual AHIs less than 1. So we got together and decided to do what is now, I think, a quite well-known study that is a randomized double-blind trial of adenotonsillectomy for childhood sleep apnea, which was published back in 2013, again with Dr. Carlos Marcus as the first author. Many centers participated, including ours. And this study had a few characteristics that are important. One, the age was the same age that you can see from the other study that I showed you. There was a little bit of a match now for sex for both of the groups. There were 2 groups. One that was randomized to adenotonsillectomy, 194 children, and one that was allowed to spend 7 months without having adenotonsillectomy, what we call watchful waiting. And the group matched very nicely between the 2. So I will not spend, but about 30% or so of these children had obesity. So you can see a little bit less obesity than what I showed you before. That's one. Second, these were children with mild sleep apnea. They did not have severe sleep apnea because otherwise it would be unethical to wait 7 months to do the treatment. So this is 2 major differences from the previous study. And again, what we found here is that for the vast majority of, as you would expect, there were that children, 88% or 70% of the children normalized their results. But remember, these were with very mild, and the majority of these children that normalized their results were the non-obese children with obesity, then making that the results were not as good as you would have wanted relative to the non-obese. So obesity, age, again, emerging as two major factors, with potentially African-American Black children being also at risk of having more likelihood of residual sleep apnea. This was also a very disappointing trial for us. But I think that we learned a lot, and you heard already from Professor Kherendish Gozal today that the consequences of sleep apnea and cognitive function are not that trivial, that there is an issue of susceptibility and an issue of who is at risk. And this was not accounted for because there was an intention to treat analysis. So there were no evidence that this improved cognitive function, even though it improved quality of life. We have a very good explanation for this because the majority of children with mild sleep apnea were not affected cognitively. So if you are not affected in your normal test, and the test is normal, how can you improve on normal? I don't know how. So, but when there was a sub-analysis done, published by Taylor in Pediatrics, there was evidence that indeed those children that were affected, actually there was an improvement confirming a lot of my previous studies. Another point that we tend to forget is that every surgery has mortality and morbidity. Let's not forget that the surgical intervention is not something that we do lightly, and that we need to consider that even though adenotonsillectomy is a very safe procedure, we need to put into attention that there are complications. And there are two major complications that we need to remember. One is respiratory complications postoperatively. Children with sleep apnea are at a much higher risk of developing postoperative respiratory complications. The other one is bleeding, okay? And hemorrhage is a very important complication, but particularly in children with recurrent tonsillitis, where respiratory complication is primarily appears to be a significant issue in children with sleep apnea. So remember that children with sleep apnea that you send for an adenotonsillectomy by your colleagues, the ENT colleagues, are also, can we predict those? And the answer is we don't know yet. We still don't know how to predict which children are going to develop respiratory complications, even though there's been multiple studies on this, but the prediction is not very good. So this is just showing you that children with sleep apnea, post-adenotonsillectomy, are much more at risk, actually have almost an 8-fold increase in risk, or 5-fold for the average of the meta-analysis, relative risk of developing respiratory complications, while children with recurrent tonsillitis have an increased risk of hemorrhage, okay? So this is a bleeding from the tonsils. So these are two diseases that I believe are very different, and yet the same treatment is applied. So one, a risk of residual sleep apnea; two, a risk of developing respiratory complications and desaturations, which at this point in time, unless we do a much larger, very large cohort and start really analyzing what are the factor loading and predictive elements, is going to be a little difficult to predict at this point. The second point, there has been a fashion among our colleagues, the ENTs, to do tonsillotomy. In other words, to leave the base of the tonsil, and just take the tonsil out, but leave the peduncle and suture the base to the throat, to the pharynx, versus tonsillectomy. And there was a substantial concern that there might be really a recurrence of sleep apnea might be much more likely after tonsillotomy, even though the early results would suggest that this is not the case. And indeed, you can see that the risk of reoperation was much higher in this study done by ENTs. So again, unbiased, and a total of 27,000 children were analyzed from the database, and the risk was almost twofold to require a repeat surgery for the tonsils versus the group that underwent tonsillectomy. So at this point in time, at least if you're going to decide to do a surgery for the tonsils, at least do a tonsillectomy and do not do a tonsillotomy. You know that when you don't know what to do in medicine, so if there is a disease that you don't know what to do about, the usual thing is give steroids. That's what we all do. And so, not surprisingly, Dr. Bob Rouillette at Montreal, at McGill University and McGill Children's, did the first very short treatment of 5 days with prednisone in 5 children with severe OSA, and he couldn't find any major benefits, but he persevered with this and did the first randomized double-blind, actually it was a triple-blind trial with fluticasone, but in kids with severe OSA, which probably this is not was not the best selection, but that was what was available. And the reason that they could do it was because they had such a time, a very long waiting time to get the children to the OR. They needed to come to do adenotonsillectomy in the operating theater, but the wait time was almost 4 months. So they said, why don't we give steroids intranasally? And let's see whether we get some improvement. And indeed, what they found in this group of very severe children, their AHI was more than 10 in all the children. They saw a substantial reduction of about 40% of their AHI over a period of 6 to 8 weeks that they gave the intranasal steroids. And they found also improvements in oxygenation. So we decided that we needed to really improve on that, and that the best criterion for starting steroids as a treatment consideration rather than just palliation before surgery was to actually go to the group that is mild. As I told you, there are consequences that are not very good, adverse consequences of surgery. So if we can avoid surgery in a large group of children that have mild OSA, this would be fantastic. And so we conducted the first randomized double-blind placebo-controlled trial with a crossover design. This was led by Dr. Leila Kherendish. And this is the design. We did this first study. We randomized to either placebo, in other words, spray in the nose twice a day with placebo, or with budesonide. Then we repeated after 6 weeks with a second PSG, allowed for a washout of 2 weeks, and then went a crossover. And then those that had been treated with placebo, they received budesonide, and those that did receive budesonide were on placebo, because we wanted to see whether there was a rebound in after treatment that would then essentially negate the validity of treating with budesonide. And these are the results. So on the results, what you see is that the pre and post, the pre is shown in black, the post in open circles. You can see that the majority of children did not improve on the control. There were some that improved, about 5 or 6 children that resolved. And this was also seen, by the way, by the CHAT study, where kids that waited and had mild disease actually improved and their disease resolved. But there were others that actually got worse. And so overall, placebo treatment did not improve the overall results, but treatment with budesonide led to a very significant improvement or resolution of the sleep apnea in a large proportion of children, suggesting that intranasal budesonide or corticosteroids actually have a role in the treatment of these children. So the important other thing was that after we stopped the treatment for 8 weeks, we saw that there was no rebound. This is important, okay? And so this indicates that this is a viable treatment. And indeed, we wanted to look at the same approach, this time with montelukast, a leukotriene receptor antagonist. The reason for this was that we had found that there are very significant densities of receptor to leukotrienes in the adenoids and tonsils of children, particularly if you have sleep apnea. And so there were 3 studies in the literature that have been done. The first one we did in 2005. This was repeated by Dr. Goldbart 7 years later, but this time in a randomized double-blind control trial. And Dr. Leila Ghazal did the third one, this time in a larger cohort, much larger cohort, that was published in 2016, and the results were very positive as well. So anti-inflammatory therapy with either intranasal corticosteroid and or leukotriene receptor antagonist leads to significant improvements in mild sleep apnea with complete resolution in about 80%. There's, however, some concerns, and this is why I'm not showing you the data for Montelukast. In the last few years, particularly in the last 12 or 18 months, there have been some concerns related to the neuropsychiatric events in children with Montelukast. I have not seen yet, I've seen in all the children that we've treated, and this has been thousands of children, we have not seen that effect because we use it only for 1 year, but this has been reported through the monitoring for children with asthma, so I have to mention it and leave it to your decision whether you want to treat with this compound or not. The important thing was also whether a child with, after adenotonsillectomy that would have residual sleep apnea would benefit from treatment with anti-inflammatory therapy. And so this was the treatment, in both combination of both Montelukast and budesonide. The children were randomized to one of the two groups if they had mild sleep apnea after adenotonsillectomy. And so what we found was that the combination of therapy led to resolution of the residual sleep apnea in all the children as opposed to control. So if you have a child with residual sleep apnea after adenotonsillectomy, you may wish to consider anti-inflammatory therapy before you start considering other therapeutic options that we will talk in a second. So the total summary of the data was that this was published in several journals. There's 6-week therapy of intranasal budesonide. I've shown you some of the data before, leads to improvement. But the cumulative experience with anti-inflammatory therapy is that an 80% of mild sleep apnea will resolve and giving the chance to not to have to operate and to do surgery. So I think that this is one area that I think we've done quite a bit of progress, and I would encourage you that to do a sleep study, and if there is between 1 and 5, or the child is symptomatic, try the anti-inflammatory therapy, repeat the study. If it's still there, then treat with surgery or do whatever you think that needs to be done, but at least give it a chance and do not rush to do adenotonsillectomy for all cases, because this would be actually a wrong decision. So what about other non-surgical initiatives? Well, positive airway pressure, rapid maxillary expansion, and myofunctional therapies are all areas that for which there's obviously indications. But I'm going to tell you that we need to talk about this in much greater detail. There is an art about starting and implementing CPAP or BiPAP or bilevel or APAP or AVAP in children with sleep apnea. There's obviously a substantial level of considerations that need to come when we do RME or rapid maxillary expansion. And as well, some of the data of myofunctional therapy are encouraging, but the data is still not sufficient to convince all of us that this is a way to go. I will share this, I will make it as a PDF and then provide it to Professor Modarisi so that he can distribute, but there are 5 cases that I've illustrated here that give some examples, and I'm going to run very quickly through one of them to give, or 2 of them very quickly, in order to illustrate some of the findings that are important. Case number 1 is a 3-year-old boy, loud snoring, recurrent night terrors, allergic rhinitis, very grumpy, difficult to arouse in the morning. Past medical history, he had RSV bronchiolitis at the age of 2 weeks. You will see that if you look in the literature, RSV is an antecedent, frequent antecedent of children with sleep apnea. So you need to keep this in mind, that viruses can leave a long-term immune memory that makes the tonsils may grow very quickly. Family history for sleep apnea was negative. Physical exam was a normal BMI, large tonsils, minimal retrognathia, and some limited nasal airflow due to the allergic rhinitis. The sleep study showed significant sleep apnea, very severe sleep apnea, which is shown here. You can see the major events with significant ongoing respiratory efforts and very severe desaturations to the 80s. This is the hypnogram showing that particularly during REM, there are very significant desaturations. As you know, in non-obese children, this is a REM disorder, okay? Primarily REM disorder. You can see some of it in non-REM, but mostly it will be concentrated in a REM disorder. You can see that this is a very severe case of sleep apnea. So not surprising, the obstructive apnea-hypopnea index was 26 per hour, and with a respiratory arousal, not total arousal, respiratory arousal index of 13 events per hour. So clearly half of his, it would wake up 13 times just because of difficulty with breathing. Tonsillectomy, adenoidectomy was done with an inpatient admission. This is important because in severe cases or in children that are young, you want to make sure that these respiratory desaturations and severe apnea may occur. So this was done, and we repeated the sleep study and completely normal. So you can see a success case that really adenotonsillectomy was sufficient. Then I give you another one, and then I'll stop. And then you will have 3 others that you can read at your leisure. 12-year-old African-American boy snores very loudly, very tired during the daytime, is doing very poorly at school. He has a disruptive behavior, very aggressive, very reactive, is thrown out of class multiple times for disturbing in class. His father has sleep apnea, but he never treated it. Physical exams, large tonsils, 3, moderate retrognathia, a narrow palate, malempathy +3, but normal nasal airflow. This is the sleep study. The hypnogram shows you very significant snoring. Each one of these is the apnea-hypopnea events. So you can see that this child has very, very severe sleep apnea as well. And when we did adenotonsillectomy, this is what we found. Well, not really. This is wishful thinking. This is not what we found. This is what we found. So adenotonsillectomy made his sleep apnea worse. Please note this. You should not. In some cases, it may actually make it worse. Please note that that's why we need to repeat sleep studies in children that we send for adenotonsillectomy. Even if the parents, by the way, we asked the parents, and the parents said that snoring had gone away, which is not surprising. So they were very happy. And to their surprise, not ours, but to their surprise, sleep apnea had not gone because this child had many other factors that you're going to discuss tomorrow with Professor Kaditis about why some children do not resolve. One is obesity. This child was not obese. This child had craniofacial and neuromuscular issues that required a complete different approach. So now this is the kid. We had to do rapid maxillary expansion. We did a computational analysis with orthodontics were put in place, expansion of the palate, expansion, advancement of the mandible. All of this took about 18 months. And after that, the sleep study completely normalized. So I'm going to stop here and leave you with as much uncertainty as you would like, but also with what I call critical thinking. It's important to think that there's, in medicine and in love, never, never, never always. Okay, so please, there's no such thing as 100% success rate in medicine, and not in love either, but more importantly for medicine. And so in any treatment, there are going to be those that are very successful, I showed you in case 1, and those in whom a standard treatment, the first line of treatment, which is adenotonsillectomy for severe sleep apnea, will result in actually worsening of the disease. So you need to be very attentive to your patients to make sure that you make the right decision based on severity, that there are side effects for every treatment that you do, that there are consequences, and therefore that it is not a simple formula that you just plug in and say, oh, this is what we do, and forget about the rest because it's going to work 100% of the time. And that's the beauty of sleep medicine. That's the beauty of taking care of these children and the challenges that they pose. And I hope that over the next few years, we will have a much better algorithms that predict at the individual level, what we call precision medicine, personalized medicine. That we are working on this. Professor Leila Gozal and I are working very hard now with Professor to establish a much more personalized type of approach for the treatment of these children in order to define a priori who is going to benefit and who is not. And maybe tomorrow you can ask Professor Kadidit about the value of nasopharyngoscopy and other techniques of dynamic imaging of the airway that can help in those predictions as well. Thank you very much for your attention.
Thank you, Professor Gozal. Actually, you left us a lot of questions. I will make sure to attend the tomorrow's session too. We are greatly honored to have you with us today, such an expert in the field of sleep medicine, a pioneer in the study of childhood sleep problems. There are some, I believe there was one question in the chat section which was answered in the speech. So I cannot see any other questions. Unless there are any other questions, I would just want to tell something. I just heard the bad news. I'm so sorry to be the bearer of sad news, but our dearest Professor Ghulam Hossein Fallahi, pediatric gastroenterologist and faculty member of Tehran University of Medical Sciences, just passed away from complications following COVID-19 infection. May he rest in peace. May my deepest sympathies goes out to his family and his students, the biggest family of Tehran University of Medical Sciences. May God give you the peace that you seek, and may my condolences bring you comfort, and may my prayers ease the pain of loss. So from each and every one of us here at Children's Medical Center, we would like to say a particular thank you to Professor Gozal, Professor Karates, Professor Khairandish, and Professor Modarresi, whose support we are honored to have, and despite the time difference, we were more than happy to get involved. A special thank you also goes to our fantastic audience. We had a certain number of 139 participants today, and we appreciate your continued cooperation with us. Please submit your questions to us on our social media. If you have anything else that you thought of after we conclude today's session, we will make sure to answer those questions. And don't forget to register on tomorrow's session, which would be the second day of the first international virtual course on pediatric sleep medicine. Thanks again, everyone, and have a good time.